Hi, good afternoon. My name is Claudia Ellison with eHealth Initiative, and I'd like to welcome everyone to today's webinar, Machine Learning and Advanced Analytics. We have a full webinar today, a fascinating webinar with two speakers, Marc Overhage, who's the Vice President and Chief Informatics Officer, Population Health at Cerner, and Dr. William Feaster, who's the Chief Health Information Officer at Children's Hospital of Orange County, and this is in Pennsylvania. So we've got a full agenda, but before we get started, just a few housekeeping. All the participants are muted. If you have any technical difficulties, you'll see two areas on your computer screen. One is for technical difficulties, and then one is a very specific Q&A box. Please just use this one for the Q&A, and this way we capture all the questions, and at the end, if we're not able to get to everyone, we can follow up with you. Today's slides are actually posted on our eHigh resource page. So just a little bit about eHealth Initiative. eHigh serves as a convener, multi-stakeholder of organizations from payers, providers, pharma, and we work together to provide best practices. We do this through research, education, advocacy activities. And as you can see from this slide, the type of members that we do have, Bristol Myers Squibb, Cerner, Johnson & Johnson, it really covers the gamut, and we are really fortunate that we've got such a really vast and interesting group of members that provide input and work with eHigh on the specific programs that we have. For example, we've got 3 different work groups: value and reimbursement, technology and analytics, and workflow for providers and patients. And we will be providing a document at the end of the year with best practices and recommendations, so please be on the lookout for that. This is just information about our resource page. Please take a look, and if there's information that you think would be interesting to include, just let us know. And then, like with all of our work, all of our webinars and programs, we could not do this without the generous support of companies such as Cerner. So we want to thank Cerner for their generosity and support of this particular webinar. So today's speakers, we've got, again, Dr. Feaster and Dr. Overhage. And on that, I will turn this over to Marc. Marc?
Thank you very much, and thanks everybody for joining this afternoon. I'm just going to do a little bit of high-level framing here and then turn it over to Dr. Feaster to dive into some more specific examples. And we're really fortunate to get to work with Bill and his team on evolving these ideas, and this is very much in an evolutionary point. If you can go to the next slide, please. I'm going to start out talking bit about a longitudinal care plan, and the reason I'm starting with that, it may seem an odd thing in the context of machine learning and AI and things, but the reason I'm starting there is that we think today that the longitudinal plan is sort of the pivot point, the connection between the intelligence in the back, if you will, and the workflows and process design that it takes to take care of patients and turn that intelligence into something useful. And if you think about care plans, the phrase has been around for a long time. I think about this as the longitudinal care plan, which is that kind of comprehensive, integrated, overarching plan that is that pivot point. There's other plans that people talk about, ED care plans and acute care plans and so on. But I think those are all fit in or are components of that longitudinal care plan. And if you go to the next slide, so in this longitudinal care plan, some people describe it as a synthesis of all plans of care. It's that sort of meta plan. Importantly, driven by the entire care team and engaging the entire care team. And I think it's important there to think about that care team not just as the professional care team, but the patient, their informal caregivers, folks like pharmacists, maybe physical therapists or visiting nurses in the ambulatory setting. Those are all parts of that team, and that's where it becomes so important to think about this in a holistic way. And then in contrast to how we've thought about plans in the past, and this is where I think the intelligence starts to come in, that they're ongoing and evolving. A longitudinal care plan isn't some static thing that's created at a point in time and worked, but rather a continuously evolving and changing list of goals and activities. And if you go to the next slide, we can dive into that just a little bit deeper. And so when we think about a care plan in this context, we think about it being based first on what are the health concerns from the perspective of the individual. So the patient is going to think about their concerns very differently than the nephrologist, who's going to think about it differently than the primary care nurse, perhaps. And those concerns include things like wellness and barriers to improved health, injuries, illness, so a broad set of things. And then there are goals. What are we trying to get done? And those are going to vary, again, in many ways by the context of the individual, the member of the care team that you're thinking about. So the patient might think about that goal of being, I want to be able to walk my daughter down the aisle at her wedding this fall, even though they had a hip replacement last week. And then in the bottom, sort of the status information about that goal, and then the activities that it's going to take to make those goals achievable. So you might have activities like the patient will learn how to use a three-pronged cane. Now there might be an activity, corresponding activity for a physical therapist or an occupational therapist related to that. There might be activities related to payment related to that, that all have to happen to achieve that goal that we're setting out to get to. And then the little gear icons here are intended to represent the bits and places where we've been beginning to insert intelligence into that process. What are the active problems? What are the goals? What are the activities that are going to take, and what are the status of those activities? And that may involve things like escalation, for example. The patient's supposed to make an appointment with their cardiologist. It's been 3 weeks. That's not happened. They've been reminded several times. You might escalate that to a care manager or other member of the care team, maybe an informal caregiver, to get that to happen. So if you go to the next slide, again, we think about this as happening, this longitudinal care plan is happening across an enterprise, and that all of the various bits and pieces, all the various plans come together into this longitudinal plan, which is continuously updated. And maybe kind of paused or suspended, the little button with the 2 bars at the bottom at various times. So when a patient's admitted to the hospital, that longitudinal plan is sort of on hold or paused while the patient's receiving acute care, where there's an episodic plan that's being worked. But then, and we think about these as transitions of care, that plan has to be integrated back into the longitudinal plan and continued. So if you go to the next slide, please. So shifting back to intelligence, so that's the pivot point, we think, and I'll talk more about that in a second. But this idea of artificial intelligence or machine learning is not really new to healthcare. It's been around a long time. There's decision support that critiques orders, documentation templates that are tailored to the patient's condition, predictive models for things like readmission or workflows for detection and management of sepsis, things like that. What's really happened, though, is that a couple of things. One is, in artificial intelligence in particular, the bar continues to be raised of what is artificial intelligence. Forward-chaining rule-based systems in the 1990s were certainly artificial intelligence and are embedded in many contemporary electronic medical record systems and other healthcare IT systems. But we kind of go, passé, that's not quite what we mean today. So the bar continues to raise. The other thing, and I think Bill's going to, is that 3 things have conspired or come together. Conspired maybe has a little negative context, it shouldn't. 3 things have come together to really advance the opportunities that we have today. First is the amount of data, both structured and unstructured, that's available, largely as a result of broad adoption of electronic medical records across both acute and ambulatory care in the US. Second is the ongoing progress in terms of availability of inexpensive computing power that allows us to take advantage of the third thing, which are true advances in the statistical/mathematical techniques that enable machine or deep learning kind of methodology. So those three things coming together: much larger data, much cheaper computing, and advances in the methods are really letting us tackle new problems and sort of respond to that raising bar. So if you go to the next slide, I think about intelligence in healthcare in four broad buckets. The first one is in data extraction, and you see a lot of this in the press these days. Things like, well, we can tell people's gender from looking at their eyebrows. Cool. So natural language processing, image analysis, video analysis, things like that, sensing our environment, interpreting radiographs. All of those things are ripe areas and actually go pretty well, and partly because the data are very regular, the data are very dense, and there are large sets of tagged images and audio, although that's still the big challenge. The second bucket that I think about are cognitive interactions. Folks probably saw the recent press over the last week or so about IBM's Debater. Very cool stuff, right? So how do you interact with machines in a more natural way? So providers and consumers able to talk or look at or those sorts of things to interact with the computer and simplify that interaction. And then the last two are a little bit different in that we're starting now to leverage more specific clinical data. And those two buckets in my mind are, one is operational process modeling. How do we make the process of care understood, predictable, and therefore manageable? Which patients are likely to leave the emergency department without being seen, and which patients who are being seen in the emergency department are likely to be admitted in the next hour, and how does that impact a workflow and the bed's availability and things of that nature. So those kinds of predictive models and process modeling for operations. And then the fourth bucket, and I separate these two partly on the basis of regulatory issues, but also partly on the basis of the types and ease of access of data. The operational data being a little bit easier to get at scale, a little bit more regular, and therefore a little more amenable to some of these processes. And then the last one is the one that we often jump to, which are clinical models, whether that's identifying patients with conditions, predicting what will happen, prescribing what process should happen, and so on. So those are the four buckets I think about intelligence in: data extraction, cognitive interaction, operational process modeling, and clinical models. So if we go to the next slide. So one example of the last bucket that Cerner has been working on is something we call healthy programs, which is really just trying to be that assistant to the care team that applies rule-based algorithms. Those can be machine learned, they can be built by humans to identify individuals with chronic conditions that need escalated care, and then to coordinate the processes of outreach, communication, and follow-up, so that rather than a human doing those tasks, let the human be freed to focus on the very challenging task of motivating patients and understanding reasons for limitations and so on. And so those are the kind of things that we think that the current state-of-the-art intelligence is most suitable for. Next slide. So as a concrete example, if you look at the management of a chronic condition like asthma, you might come up with a flowchart, something like this, where the tasks are divided between the members of the care team, the patient at the bottom in the sort of rusty orange, other things in blue and red that represent other members of the care team. And don't worry too much about the details here, but the point is a few kind of orangey red things, a few blue things, and lots of boxes. And if you go to the next slide, If you then analyze that and say, well, what of those things have to be human tasks and what of those things can the computer do well? You can replace a number of those tasks now in green by automation or intelligence. For example, notifying the care team of a new patient who's newly enrolled in a care management program, or identifying negative trends in the data. Those are things that the machine can do very well and leverage and free up human time, more of the care team time, to do the more difficult, higher value tasks. So the takeaway here is just that a lot of those boxes can be turned green, can be automated through intelligence, and free up the humans. Next slide. And so this just as an example, we have begun to create these type of virtual assistants, and they take a whole collection of rules and actions and so on to implement and create value. So if you go to the next slide. And then the last bit, and this is why I started with the care plan, is that all of those activities that get identified by the intelligence, those tasks, need to get integrated into the clinical and non-clinical, for that matter, workflows. And so a lot of the work that we've been focused on is how to take those actions or activities that get generated for the care plan and translate those into, in a standardized way, using HL7 Fire resources as the foundation, into the processes that already exist. So for example, if we need to communicate with the patient to collect some data, being able to make that request of the patient through their patient portal with notifications on their cell phone, for example, or things of that nature. So there's a lot of work to be done to standardize the ways that that intelligence can be integrated into the workflow. And we think using the longitudinal plan as the pivot, or the thing that lets us do that at scale and reproducibly. And if you go to the next slide, and I'm going to hand this over to Dr. Feaster in just a second. We think there's a number of benefits to this kind of an integrated system where there's data-driven, modern sort of engagement. And if you go to the next slide, just some specific examples in terms of improved patient recruitment, satisfaction, and retention, the ability to automate a large fraction of those processes so that you're not having to have as many people involved in those activities, simplifying outreach and referrals. Here are a number of examples of the kinds of things that we think automation can help with very specifically. Next slide. Improving the costs simply by better personalization or closing more of the gaps in care, as well as proactive, more frequent interaction with members of the care team. And then integrating the patient and provider interactions better by allowing the intelligence to know when these various activities have happened and triggered that next phase or that next step in communication, making it more seamless and smooth for that interaction. Next slide. And then the last couple points here, to improve business efficiencies, and that can come in a variety of ways as listed here. And then at the end, and we think this is a really important part of things, is we think of this as sort of closing the loop. It's that learning healthcare system part of this structure. As you build this sort of chain from intelligence via the longitudinal plan into the workflow, critical that we capture the data and then leverage it and learn from it in using the same techniques to improve that process and the set of outcomes. And we think that that closing the loop is a critical bit of implementing this entire chain. So with that, I am going to turn this over to Dr. Feaster, who's going to dive into some more specifics, and look forward to the questions. Thank you.
Hey, hello everybody. Bill Feaster from CHOC Children's Hospital. Just a little correction, we're in sunny Southern California, so not in Pennsylvania. What I want to try to cover in this presentation is to really sort of outline how we've leveraged our EMR data to advance population health, how we've applied data science to our data to improve patient satisfaction and safety, and how we're beginning to explore our data with advanced artificial intelligence tools. Now that's all, more future stuff, because a lot of the work we've done to date has been primarily with selected data sets and sort of standard inferential statistics. Now a little disclaimer at the front of this, I am not a data scientist. Dr. Overhage has much better data science chops than I do. I had the kind of the foresight to hire a data scientist. That is about my only claim to fame, and I work very closely with him, and we're going to be talking about several of the things that have come out of that collaboration. Next slide. Okay, a little bit about CHOC. We're in Orange County, right near Disneyland, as opposed to the other Orange County, which is by Disney World in Florida. We're a medium-sized children's hospital. We have a secondary hospital, and together we're getting close to about 400 beds. One thing in the lower left corner, though, one thing that makes us a little different is that we've had 150,000 fully at-risk Medicaid or Medi-Cal in California lives that we've been responsible for over 20 years, and we have about 50,000 commercial lives. That's kind of the reason why we have more to talk about in terms of population health. We're a typical academic affiliated institution with residents in research, et cetera. Next slide. Now, we're very proud of all of the awards we get, and everybody always puts an award slide, but I want to sort of point out our HIMSS EMR adoption model stage 7 certification that we were just recertified for. That's basically the top level of EMR adoption that HIMSS Analytics kind of determines for organizations, and it represents 3 to 4% of all the hospitals in the United States that have achieved that level. Next slide. And one thing that I am particularly proud of is that every year the Health Information Management Systems Society, or HIMSS, awards the Nicholas E. Davies Award for work using your EMR to improve quality and patient safety. And we were, I believe, the third children's hospital ever to receive that award in 2016. So very proud of that. Gives you a hint of kind of where we're focusing our efforts these days by utilizing our EMR. Next slide. Okay, well, just like all of you, healthcare is absolutely awash in the sea of data. It's nice that we're in Southern California near all the waves, but we certainly have that problem here in Southern California just as you do throughout the country. Next slide. So we now even have more data because we have access to whole populations of patients, not those receiving hospital-based services. Traditionally, our EMR was in the hospital. Well, now we have all our ambulatory data. We're going to have primary care data soon on over 300,000 patients in Orange County, which has a population of about 750,000 children and about 3 million patients overall. Our population health data warehouse now has claims from our IPA and multiple other data sources, including eligibility, pharmacy, lab, et cetera. So this is quite a tsunami, not just a wave, but a tsunami of data. And then we're also bringing in data from other facilities through our local HIE, and then unloading multiple practice data via 837 billing claims. So there's no end in sight for what's happening. Next slide. So compared to other industries, we don't take advantage of all this data very well. For example, even at our organization, a lot of our quality and registry reporting is still obtained by manual chart abstraction, and by registries here, I mean like cystic fibrosis registry, cardiac surgery registry, and the like. We manage our at-risk populations in healthcare, but often we rely on 3-month-old claims data to track care of what happened 2 or 3 months ago when someone submitted a bill. We widely report patient satisfaction data throughout our organization, and we have all sorts of plans on how to improve it, but we use assumptions of what's underlying that dissatisfaction to create those improvement plans. And we are looking at patients either at the time of discharge or during their hospital stay and using our gut, our clinical judgment to determine either patient deterioration or readmission risk. And most of the time it works pretty well, but we don't have much data that we apply to that. Next slide. So famous quote from W. Edwards Deming, who's kind of the father of the process improvement. In God we trust, all others must bring data. I would have one clarification of that quote. Next slide. Next. I would say, in God we trust, all others must bring intelligence. And that's really our point here. How do we turn all that data into intelligence? Next slide. So the first kind of next section of the talk, I'm going to talk about how we're leveraging data to advance the health of our populations. Next slide. Now, we, in 2014, because of our experience in value-based care or in risk-based care, we decided that we needed to adopt a population health platform, and we adopted Cerner's Healthy Intent platform. And it basically includes at the left the ability to acquire data from multiple sources and bring them into a big data platform based on Hadoop. And then the magic occurs behind the curtain of Healthy Intent, where all that data coming in from all these different sources is cleaned up, it's normalized, it is matched to patients so that it's a unique patient that we get the data from, normalized to various standardized nomenclature, et cetera, and it creates a population health record that different solutions run on. And I'm going to be talking about a couple of these solutions today. Next, the first thing I'm going to be talking about is our smart registries, and talk a little bit about why we chose registries and why we're using them to help manage our population. Next slide. So why did we implement and develop these registries? Well, next, we have a lot of care guidelines, and this is an example of an asthma care guideline. Now, a clinician looking at this certainly would glaze over and probably close the book that it's in, that's in a binder with laminated sheets or however you might implement guidelines like this, and it would become mostly useless. So next, we needed a tool set that we could, in the inpatient environment, we had pretty good tools for implementing guidelines. But in the ambulatory environment, those really weren't in place. And the other thing we need next is, in addition to implementing the tools, we want to be able to get the data out in a very accurate form on how care is being delivered to, say, those patients with asthma, which is one of our key guidelines we've been implementing. Next. So we helped Cerner develop initially 7 disease-specific, condition-specific registries around asthma, not real mild cases, but persistent and fairly severe cases of asthma, juvenile onset diabetes, seizures, et cetera. And then since then, we've worked collaboratively with National Children's and Boston Children's to develop some other guidelines, waiting soon for autism to come out of development, because I think that's something that's going to be pretty popular amongst our clinicians. Next. So, okay, so we developed all these registries. How do we really get value from their use? Next slide. So the first thing is, this registry data is available right when someone's seeing the patient at the point of care. Because one of the problems with data that's sent to doctors about how they're managing a population of patients is they get the information a month after they took care of a patient, or maybe 3 months after they took care of the patient. There's not much they could do about it at that point. But here, right at the point of care, they're seeing the data on that patient on how they're tracking according to a guideline. Now, this is a pediatric epilepsy guideline on the left side of the slide. And it says that there are a couple missing things. One, the patient's not getting the follow-up visits they need, and they don't have a seizure action plan. So that's something that maybe scheduling another follow-up visit and implementing that action plan could be done in that visit right then, and avoid having to call the patient back, et cetera. Next slide. The registry data is also available to the practice leadership to track compliance with all these different measures. A registry classifies a group of patients with a certain disease, and it has all kinds of measures that are guided by, say, a national guideline that you need to follow. So an example here is the asthma action plan, which is something that's widely accepted as a standard of care in the care of patients with asthma and is part of the AAP guidelines. And we can see that this particular practice at this particular date only had 36% of their patients having an asthma action plan. So we can review that data. The other thing is the individual clinician can do that as well. Next slide. How do we work these guidelines into workflow? Because it doesn't do much good just to have it in the clinician's chart, because they're busy and they're going to be kind of blowing through that patient visit pretty quickly. But instead, how can you work this into workflow? Next slide. So we focused a lot on asthma, trying to figure out how we could really improve the various metrics in asthma, because it is our most frequent cause of ED visits, the highest rate of hospitalizations in our capitated population. There's the largest variation in care, and there's a fair amount of high morbidity, poor outcomes. It's not well assessed, et cetera. So we decided to really spend a lot of time, now that we have this new tool of the registry, asthma registry, how are we going to do all these things in that population? Next slide. Well, this is some of the data in compliance to measures over time. And when we started out on the left side of the graph, it's 2000, I guess that's 16, the first quarter of 2016 for this particular practice. They were at about, for asthma action plans, at about 16%. And at the end of first quarter of 2018, they had gone up to 50%. Now that's actually pretty good, since they haven't seen all the patients yet to actually give them an action plan when they haven't had it. And partly it's through that guideline through the registry being available in the EMR. Part of it's through the workflow, where they have a huddle in the morning where they talk about which patients need what, which asthmatic patients need what today when they're coming in. So that's been fairly impressive progress. Now, down below is a physician view. Well, we can also tell that some physicians are doing really well, and some physicians aren't really performing at the level we want them to perform. So it allows us to track data like this and to intervene and to get performance improvement. Next slide. The other thing we're doing now in using some of our specialty registries is to actually choose metrics that we can measure and track for improvement. This is just an example of some of the things that would be used by our neurology or our endocrinology. And for example, for pediatric diabetes, for having a measure that we want improvement on is hemoglobin A1C less than 10%. Well, only 77% of our kids are actually making that as of this current assessment. I think they're up higher now. But part of the problem is if all you have is just, well, what the patient's HbA1c that day is, it's kind of hard to create a program around that patient for improvement. And so what we're doing is taking these, say, 3 of these specific measures for each practice and having them focus improvement efforts and then feeding back data to them as we can. Next slide. So we also have an enterprise data warehouse as part of this healthy intent system. Why not just report on these measures? Why do I need a registry specifically? And some of the features of the registry makes reporting off registry data incredibly valuable. And one, the population is defined very carefully through inclusion and exclusion criteria. There are relevant processes and outcome measures identified, and those measures are defined with inclusion and exclusion criteria. Those registry data elements are mapped very carefully to those within the EDW, and then we validate everything to make sure. You don't want to give a doctor data on his care or her care if it's not accurate, or you lose your credibility initially. When we first did our asthma action plan and showed providers they had a 16% compliance, they immediately were skeptical, but proving it with consistency and good data made all the difference. And the other thing is the registry is then attributed to specific providers with specific algorithms for different types of providers. So it's very different than just doing a simple report off of an EDW. Next slide. And I've been likening this to data curation. And if you look in Wikipedia, they have a definition of curation of data. But in effect, you basically, through all those criteria I just mentioned, you have pretty much registry data is then fully curated. And when you report off of it, you can be very confident that what you're reporting actually truly reflects the care being delivered. And so I've been focusing lately on using that term. Next slide. Now I'm going to focus for a minute on another aspect of the Healthy Intent platform that Marc covered, and that's healthy programs. We're helping Cerner develop healthy programs also for asthma, for pediatric asthma. Next slide. So basically, this is an AI-based alerting platform for asthma. And we're going through the registry of asthma patients that have been defined as having being asthmatics, but we're going through and checking to make sure they're properly diagnosed. And we're also looking to see what their level of control is. And are we classifying properly? Are they on the right medications? And are they adequately controlled? We are hoping to leverage big data sources like environmental data soon and social determinant data. We're also implementing peak flow meters for home device data to be collected in the system and using alerts that are constructed to feed into the portal for the patients, to care managers, to caretakers, et cetera, through the alerting based on this intelligence. This is all under construction and will be available soon. Next slide. This is kind of an example of one day where there was this is basically a hypothetical, what has led us to actually provide the roadmap for developing this product. So automatic alerts, I don't know whether you saw it real quickly there, maybe go back a slide. Can we go back? Okay, and then an automatic alert is being sent out to the parents and to the school nurse one day when the air quality has become quite poor, and we've noticed that Maria in the past tends to react negatively to poor air quality. Next slide. So that goes out, and it's asking Maria, next slide, to go ahead and use her peak flow meter and measure a peak flow. And so this happens at school, and not exactly what we're using now. This is, it's not hooked up to an iPad. It's a different kind of device, but she does her peak flow. And next slide. It turns out that that peak flow is not the best for Maria. It puts her into yellow, green, red. It puts her into the yellow zone, the caution zone of her asthma action plan. And a care manager now is going to be helping Maria with her care. Next slide. I'm sorry, the other point in that is that she then has an appointment scheduled in our asthma van, and she goes and gets seen. Care is implemented. She gets intensive treatment there, and a hospital admission or a trip to the ED is averted. So that's kind of what the healthy programs are helping us do. Now, the third section here is applying data science to improve quality and patient satisfaction. Next slide. Okay, so the first thing I'm going to talk about is patient satisfaction. We've always made lots of assumptions, and we get reports out from organizations that do patient satisfaction. We report that out to everybody in the organization. We make a lot of assumptions on how we're going to improve that. But I don't know whether people realize it or not, that when you get the results from your satisfaction data, you also have the identification of the patient, in our case, parent, who's submitting that response. Using those patient identifiers, we can go back to the EMR and figure out what other things might be related that's in the EMR to those patient satisfaction results. For example, next slide. In this particular article that we published, we looked at the impact of anesthesiologists, or actually looked at, in general, patient satisfaction in the outpatient surgery area. And we found, next slide, we found that a lot of things that you think would be associated with satisfaction, like the pain score post-op, whether the kid was nauseated and vomiting, the time that the kid spent in the PACU, whether the case started on time, and all of those things, turns out, were not statistically significant predictors of satisfaction, which kind of really led to us scratching our head, because we always thought those things were really important for satisfaction per se. They're important for good care, but it turns out that the perioperative communication with the anesthesiologist was the most likely predictor of patient satisfaction, and not necessarily the surgeon. What was second most likely to be a predictor of satisfaction was the nurse's communication. So that's kind of an interesting finding. Next slide. We also looked at inpatient satisfaction that was published in Clinical Pediatrics in 2017. Next slide. Some interesting things came out of that as well. For example, at a previous hospital I was practicing in, there was always an assumption of why the really low patient satisfaction scores that might be due to Spanish-speaking patients that didn't understand us and just had unrealistic expectations of care. And that was kind of like conventional wisdom at that organization. Well, when we actually looked at it here, it turns out that low parental socioeconomic status and Spanish-speaking patients were the very most highly satisfied of all our patients. A couple of weird things sorted out, like, for example, the parents of male children were much less likely to be satisfied than parents of female children. And that really got us kind of wondering, but then we looked at it, and I think we are, we looked in our store that you buy things for kids. There's nothing in there for male children. It's all for girls, because everyone buys stuff for girls. And all our, so we don't know quite why that is, but you sometimes find things that kind of surprise you when you actually look at data. Next slide. We've done some studies on readmissions, and we're real happy with those studies because they're showing us some, hopefully will show us some results soon. We've done almost everything we can to improve 7-day readmissions, which is a metric that we follow for pediatrics. And we have done absolutely nothing for the last many years. Now we're turning to data science. Next slide. So we first looked at 7-day readmissions, and we found that there was a significant impact of malnutrition on 7-day readmissions. And in fact, up to about 5-fold increase in infants of those that were malnourished versus those with normal nutrition. Next slide. And I mentioned that. Go ahead, next slide. And then we're now really proceeding with we proceed with another study of unplanned 30-day pediatric readmissions. That also is a good predictor of 7-day readmissions. Next slide. And the study takes into account novel variables that weren't previously in the literature, such as a predictive algorithm called the Rothman index. That's live in our system, whether a kid had prior readmissions. You'd think that was significant. It was never included. Things like diagnoses, medication classes. And we're up to now, by including other variables, up to about a predictive value area under the curve of 0.83. And everything over about 0.8 is highly predictive in these models. Next slide. And the key now is, how do you implement this algorithm? It's one thing to decide that here's this fancy algorithm, but how do you actually use it to improve care? So our focus right now is really on how we implement it, and we'll be hopefully publishing our results soon on this, and actually seeing finally a budge in that readmission percentage. Next slide. Now, last thing I wanted to just mention is how we're exploring data with advanced artificial intelligence tools. Next slide. So we've made a lot of progress. I've talked about a lot of studies, but we've really been limited by our computing resources. And we're still doing fairly traditional data science using discrete data for our projects. And we extract this data into a rapidly expanding data warehouse. We manipulate this data with whatever compute equipment we have. But one of the problems is, with traditional data science, we're still limited to figuring out what data might be appropriate to expose any model to, rather than letting the machine itself learn from a much larger data set. Next slide. So we're hoping now to make even greater strides using another product that is an offshoot of the Healthy Intent platform, or population health platform, which is called Healthy Data Lab. We were approached by Cerner to become the development partner for this environment, and we now have data from our Healthy Intent platform uploaded into Amazon Web Services. And so the key here is that all of that data is going to be in an environment that has basically infinite expandability in terms of capacity to store data, and no limit to the computing resources that you need to analyze that data. So my data scientist is going to begin in July working full-time in that environment to see. So we have several projects that we're going to be kicking off. Next slide. And a couple that we want to work on, we already have an inpatient mortality model of patient deterioration, but we're going to try to refine that for early prediction of ICU transports. And hopefully we can avoid late care complications by late transfers, and to work on seeing if we can't classify patients for their no-show tendency. But instead of just assuming that this or that factor is involved, we'll let the machine help us figure out what are those important factors that tend to lead to a no-show. So that, I believe, is the end of the presentation from my part. I left you with a quote talking about all these models from a famous statistician, English statistician, that says all of these models are wrong, but some are useful. And I think that's true in data science in general. Nothing is perfectly right, but we're using that data and data science to improve care. Thanks.
Well, I want to thank both of our speakers for just really a fascinating presentation. We have time for a few questions, so I'll go ahead and start with that process. The first question is, where does the goal live? Or I'm not live or live? How are all the stakeholders informed, and how do they interact and communicate with each other, providers and caregivers?
So this is Mark. I'll hop in on that one. I assume this is sort of driven by the notion of having a shared longitudinal plan. And I think the key word there is shared. When you say, where does the goal live? Clearly that's got to be a shared set of goals. They might have different perspectives depending on who you are in the care team. But we think of that as being a non-application specific plan. And so much like, and I'll tie this together with one of the other questions and maybe address it at the same time. So we think of the population health level of things, and Dr. Feaster talked about Healthy Intent, is Cerner's platform for that, is it's not just EMR data, it's data, whether that's claims data, data from a Fitbit, data from other EMRs than Cerner's. You have to have that platform to aggregate that data to drive these kinds of processes. And that's also sort of the level that we think about having that kind of shared information like goals. And also why I emphasize the importance of building those around international standards like the FHIR activity models, so that those goals can be addressed, or those activities can be addressed, changed, edited by multiple applications. And then, of course, part of the intelligence that has to be built and is not yet built is that driver for interaction between members of the care team. And I think that's actually going to be one of the more nuanced pieces of intelligence to create.
Thank you, Mark. Dr. Feaster, do you want to add on to that question, or should I go on to the next?
Why don't we hit another one?
All right. How are you handling non-clinically generated data, like the data from Apple Watch, Fitbit, et cetera? Do you consider any of it in the analytics?
Well, we have the ability to incorporate that data. We have not yet done that for pediatrics. It's probably more of an issue for adult medicine, particularly if you are, if you have exercise regimens for patients with different chronic diseases. You want to see that they're out walking and getting some exercise. It can be done, and we have the way to import it set up. We're just not doing that currently.
And just as a concrete example, though, in Dr. Feaster's work, he mentioned the peak flow meters that they're using, a little bit different in that it's sort of a prescribed device versus a personally acquired device, but the same set of issues. And so, for example, part of what the teams are doing are building predictive models using the data from those peak flow meters that, you know, classically we've had kind of this red, yellow, blue kind of monitoring, and it requires a person to look at it and decide, but you can build the algorithms to do that. So to me, a completely parallel example, just the data happens to come from a little more sophisticated prescribed device instead of a personally purchased device.
Thank you. Another question. Could you talk about the patients with medical complexity under development for the Pediatric Healthy Registries? Would patients with comorbidities have separate condition-specific registries for the clinician to keep track of?
Well, the good news in pediatrics is that there are some patients that have lots of different diagnoses, but most kids just have one thing wrong with them, so we're kind of lucky as opposed to in adult care. There is a registry that National has been working on and developed on kids with medical complexity, but part of the problem is I think that's more of an issue relevant to care management than it is to registries, because you have kids with multiple devices, they have multiple doctor visits, just coordinating their care is one of the biggest problems, and they have such varied conditions that lead to the same level of complexity. So that's they may be on several registries, and in fact they need care along those registries, but I think it's more care management.
Okay, Mark, do you want to add on to that?
I think Bill's got it.
Okay. Now, what about, Mark, for you, what Cerner efforts are planned or implemented to impact opioid guideline adherence?
So, and this is a great example of where we're trying to take a very open approach. So, opioid problem is a very challenging one for a variety of reasons. And as many of you know, there's lots of organizations, federal agencies and so on working the problem, if you will. And so what we want to make sure we're able to do is take the best knowledge from those organizations. So the CDC, for example, has converted some of their opioid treatment guidelines into a standardized representation, something called CQL, or clinical quality language, written against FHIR version 3 data models. And we're able to actually take that knowledge, if you will, that developed by a third party and deploy it into the production systems. So rather than having to rely on Cerner engineers to write everything, not necessarily to create the knowledge, but to actually write it, creating pathways using standardized formats, again, international standards like FHIR and they're not quite standards, but things like CQL, that are in process to standards, in order to represent that knowledge, in this case, human-generated intelligence, to deploy it into the workflows, and hopefully that will be part of the solution, but I'm sure only part of that very complex problem.
We have time for one more question. What steps do you take to move from predictive to prescriptive analytics? Machine learning capitalizes on existing trends and relationships, correlations in the data, some or many of which are spurious relationships and would lead you down the wrong path for prescribing and the intervention.
You want to take that one?
Yeah, let me take a little bit of that one. You can predict lots of different things, but then how do you then get people to actually follow those predictions and do something? And whether that's through an alert that's fired to the clinician about a prediction that occurs, whether it's suggesting a guideline that they should follow for a particular circumstance. What we're doing in the predicting readmission risk is that we're really relying on people. Rather than being particularly prescriptive, we're giving the information, the predictions to people, and having people develop routines around those predictions and seeing how they are able to actually leverage their health care, their care better, and can they avoid that subsequent readmission through changing what they do for patients at risk. I think in the healthy programs for asthma, we're going to be a little more prescriptive in that we're actually getting people to schedule appointments, to follow up care, et cetera, based on their asthma action plan. So that's getting a little more towards the prescriptive side. Mark, do you have any other comments?
The only thing I'd add is, I think it's a wonderful question and a really important one, because there is high risk of being led astray. And I think that some of the tools that Dr. Feaster was describing, like Healthy Data Lab, are intended to help with that, in the sense of once you, and this isn't new, this is the same thing we've done with clinical decision support for decades. It's really important when you think you have an insight, or you think you know, now have a way to drive a prescriptive bit of the process, and I think it's often just a bit of the process, that you really have to carefully test those in production with real patients in real time, not necessarily showing it to the clinician though, and monitoring the outcomes and process. So not just that testing of the algorithm, but the testing and deployment against the same populations that you're going to be running against and so on are critical parts of the overall process. Just having the model as part of the battle, testing and evaluating it, deploying it, making sure that it fits into the workflow and so on, are at least another half of the effort.
Well, I think on that note, it's actually past the hour, and I guess we better close up. But this has been a really interesting discussion. I want to thank our speakers, Dr. Overhage and Dr. Feaster, for just a very informative discussion. So thank you too, and thanks again to Cerner for supporting this webinar, and thank you to all the participants. So I wish all of you a good rest of your afternoon.
Okay, thank you.